40-year-old vegan executive with long-standing rheumatoid arthritis presents with fatigue. Vegan executive, hemoglobin 9.1, MCV 78, elevated serum ferritin, reduced serum iron. What is your diagnosis? What is your diagnosis? Anemia of chronic disease. Now, why I wanted specifically you to not mark this as something like what people are saying. भाई MCV value 78 है ना. सारे vegan patients को megaloblastic anemia नहीं होता भाई. They are always at high risk, but you have to read the question carefully. Now, vegan is a hint, not a diagnosis. MCV तो less है ना इसका, and then microcytic hypochromic anemia will be the reason. Then he is having rheumatoid arthritis also, which is an example of a chronic inflammatory condition. But vegan is a pointer. Rheumatoid arthritis is a pointer. What is the actual thing which will help you to make a diagnosis? Actual thing is elevated ferritin, reduced serum iron, low TIBC. So, of course, I'm thinking in terms of AOCD. And why is AOCD important? Because this is going to be associated with increase in the hepcidin levels. Increase in the hepcidin levels. I hope this is clear. In which condition will I think in terms of option D? Bone marrow examination revealing me presence of iron sequestration in the mitochondria. This will be a feature of sideroblastic anemia. This will be a feature of sideroblastic anemia. यार inflammation में hepcidin बढ़ जाता है ना दोस्त. What are the causes of reversible type of sideroblastic anemia? Alcohol, lead poisoning, B6 deficiency. Reversible causes of sideroblastic anemia: alcohol intake. Stop alcohol, patient will get better. Lead poisoning, treat lead poisoning, patient will get better. Pyridoxine deficiency, give him B6, patient will get better. What are the causes of irreversible sideroblastic anemia? Genetic causes. Genetic causes. So delta ALA synthase problem or ferrochelatase problem. That's what we need to know. Next one, young adult, episodic pallor and jaundice, CBC, mild anemia, increased LDH, haptoglobin, reduced static count, no hemoglobinuria, DCT negative, normocytic RBCs, anisocytosis, poikilocytosis. Next step. Should I be doing osmotic fragility test? Answer is no, because there is normocytic RBCs with anisocytosis, poikilocytosis. There is no pallor. There is no requirement so far as spherocytosis is concerned. Osmotic fragility doesn't give you anything, right? It will just give you the fact that the patient is going to be having fragile RBCs. Can it give you a diagnosis? The answer is no. Serum ferritin, is it required? The answer is no. Why? Because my patient is having anemia plus jaundice. Anemia plus jaundice means I have to think in terms of hemolytic anemia. Anemia plus jaundice means hemolytic anemia. Now, there is no hemoglobinuria. So, logically speaking, I can rule out CD56 and CD55 and CD59 problem as well. This would have been a case of PNH, paroxysmal nocturnal hemoglobinuria, right? If I rule out these, then the option would be C. Now, I know this question comes with a star because there is a certain factual error, and the factual error would be twofold factual error. One factual error is that in case of G6PD deficiency, there is going to be a transient increase in the retic count. I know, I'll just sort out the controversy. Second is likely the patient is going to be having hemoglobinuria is likely to be present. But in this question, it made a mention of it is not there. The only reason I'm preferring G6PD is because G6PD is a very important reason for development of episodic pallor and jaundice. That is the only thing that I have for supporting this. I know there is a factual error in the question. I mean, in order to make a question which can confuse you, there is a possibility that the person making a question can also get confused. No, the reason is not mentioned. There might be some trigger. It could be infection, it could be drug intake, it could be intake of something like something the patient has eaten. I have not given you the trigger. If I would have given you the trigger, of course, you would have gone in favor of something like the serum ferritin study will give you what? Serum ferritin study is going to be carried out only if I'm suspecting iron deficiency anemia. Na? In iron deficiency anemia, I will not be having the presence of jaundice. Na? What will explain? Increase LDH. Increase LDH, decrease haptoglobin. All this is going to be explaining. So jaundice, increase LDH, haptoglobin means hemolytic anemia. That means hemolytic anemia. So that is why serum ferritin is ruled out. Serum ferritin, why will you do serum ferritin? Na? Only in case of patient who is going to be having iron deficiency. Na? Why will you otherwise do it? It is one of the early indicators of iron deficiency. Na? That is why we prefer to do it. But I am not suspecting iron deficiency. Flow cytometry CD55, CD59 is ruled out for the simple reason that in this condition, I expect there is an alteration in the color of urine. I expect there is going to be hemoglobinuria. That's a classical cleansing thing for PNH. Or I would have thought in terms of a patient having a history of abdominal pain because of something like Budd-Chiari syndrome. But both of them are not there. There is no hemoglobinuria, there is no abdominal pain. So that is why I'm ruling out PNH also. Osmotic fragility is something which is just going to be giving me a hint whether I'm having normal cells or whether I'm having cells which are going to be spherical in shape. Spherical cells will have increased osmotic fragility, normal cells will have normal one. And there can be a condition like iron deficiency anemia or for that matter thalassemia in which the patients can be having decreased osmotic fragility. But it is a vague thing. I mean, I do not get a diagnosis with osmotic fragility. Osmotic fragility, you can say, is just for the purpose of, in a way, you can say screening. It just gives you a hint. It just gives you direction. Either jana hai. It does not lead you to the diagnosis. It's not confirmatory. Right? So that is why I'm saying that the question should have been framed better. I would have rather been having it as increased retic count, maybe. Or I would have said we should have changed it. I mean, something which should have gone more in favor of. Or I would have made it in a way. I can just reframe the question over here. I should have made it like something like, let's say, young male on a trip, right? So X-linked recessive would have gone in favor of something like maybe G6PD deficiency. That could have been a hint. कूम्स टेस्ट तो वैसे ही दिया था यार कंफ्यूज करने के लिए मैं मल्टीपल क्वेश्चंस बना रहा था सो दैट्स व्हाट आई एम सेइंग ना सो एडमिट टू द फैक्ट आई वाज मेकिंग अ क्वेश्चन व्हिच वाज टू कंफ्यूज यू बट मे बी during the process of making the question I just mixed or jumbled couple of facts, right? What is the confirmatory investigation for PNH? Confirmatory investigation for PNH? No, you should not be confused, Dr. Kriti. Flow cytometry. What kind of flow cytometry? That is flare flow cytometry. Pretty good. 45-year-old man presents with fever, fatigue, weight loss, history of mitral valve prolapse, new systolic murmur, blood culture positive, echo shows vegetations. Your diagnosis is clear. So you're having a patient who's going to be diagnosed with what? You're having a patient who has been diagnosed with something like infective endocarditis. Where do we have the vegetation for infective endocarditis? The vegetation can be present on the upper valvular surface. Ring abscess, upper valvular surface. What is the vegetation made up of? Fibrin, neutrophils, and there is bacteria. Fibrin, neutrophils, and there is bacteria. Just recall the vegetations that we talked about earlier. What is the location of vegetations in case of rheumatic heart disease? Location. They are firm line of closure. Firm and line of closure. What about LSC? Both valvular surface, lower surface more than upper surface. Lower surface more than upper surface. NBT, merantic endocarditis, 2024's question. So carcinoma patients. So patients who are going to be having a long line of closure, but they can embolize. They can embolize. And if I'm talking about infective endocarditis, large bulky vegetations on the upper valvular surface, high chances of embolization. Which one of them is going to be having lowest chance of embolization? Lowest chance. Of course, rheumatic heart disease. Maximum chance of embolization. Of course, infective endocarditis. Commonest valve affected in case of rheumatic heart disease, mitral valve. Rarest valve affected in case of rheumatic heart disease, pulmonary valve. These are all exam questions, है ना? मत भी. MATP. That's what it told. Patient presents with mucocutaneous bleed and prolonged bleeding time. Platelet aggregation reveals normal response to ADP, epinephrine, collagen, but absent response to ristocetin. It does not correct with normal plasma. Whenever I'm going to be talking about ADP, collagen, epinephrine, these are called as ACE substances. They are helpful for checking aggregation. Which two molecules are required for aggregation? Glycoprotein, 2B, and fibrinogen. So if there is going to be a normal aggregation response, that means glycoprotein 2B and fibrinogen are normal. Glanzmann's is a problem of 2B, so this is ruled out. This cannot be the answer because 2B is normal. Afibrinogenemia cannot be the answer because fibrinogen is normal. My patient is having abnormal response to ristocetin. Ristocetin response is abnormal in two conditions: von Willebrand disease, Bernard-Soulier syndrome. How will I differentiate between them? Von Willebrand disease is going to respond to plasma. Plasma makes it better. Plasma cannot treat Bernard-Soulier. Bernard-Soulier is a genetic problem of glycoprotein 1B. Plasma contains von Willebrand factor. So if I do a mixing study with von Willebrand factor patients, they are going to improve. So that is why von Willebrand is ruled out, and therefore the answer is Bernard-Soulier syndrome. Very, very likely asked concept in the exam because the topics have been asked in the exam very frequently. This question has not been asked in the exam so far. So I want you to remember that one line, that plasma corrects von Willebrand's disease. Plasma cannot correct Bernard-Soulier syndrome. In which of these conditions I am going to be having a presence of big size platelets? Big size platelets. Big size platelets are a feature of Bernard-Soulier. That's a previous INI-CET question. Ristocetin is going to cause interaction between here. This is ristocetin. This is endothelial cell. This is von Willebrand factor. These are platelets. This factor is glycoprotein 1B. This molecule is von Willebrand factor. Both of them are going to increase with ristocetin. Ristocetin increases the interaction between von Willebrand factor and glycoprotein 1B. रिस्टोसेटिन एग्लूटिनेशन टेस्ट होता है यार, एग्रीगेशन तो होता ही नहीं है ना डॉक्टर विष्णु. इट इज कॉल्ड एज रिस्टोसेटिन एग्लूटिनेशन टेस्ट. एग्लूटिनेशन में एडिशन आता है ना एग्रीगेशन आता है वर्ड. ठीक है, रैट टेस्ट जो बोलते हैं ना, दैट इज रिस्टोसेटिन एग्लूटिनेशन टेस्ट. कुछ कुछ लोग और कुछ किताबें बोलती हैं गलत भाई, तो हम ठीक कर लेंगे उसको. ठीक है, नो प्रॉब्लम्स. सो दैट इज व्हाई द आंसर ओवर हियर इज Bernard-Soulier syndrome. Which blood component can be given for von Willebrand disease? Which blood component can be given for von Willebrand disease? Cryoprecipitate. FFP क्यों दे रहे हो भाई? Cryoprecipitate is given for 4 things ना, मिशन क्लास में याद भी कराया था ऐसे ही करके. VWF, factor 8, factor 1 and factor 13. VWF, factor 8, factor 1, factor 13. For these 4 factors, you need to remember about cryoprecipitate. ठीक है, that is what you need to remember. So this is about till question number 35. Next question देख लेते हैं. 50-year-old woman who is presenting because she is having a presence of a lump in her breast. And she is having a bloody nipple discharge, and core biopsy has been performed, and histopathology reveals sheet of pleomorphic cells infiltrating the stroma with the formation of glandular structure. So primarily, the question is talking about a patient who is likely to be suffering from CA breast, and then which of the following is not true? Just read it, not true. So diaminobenzidine is useful for brown color in IHC. This happens to be perfectly true. This was a INI-CET question as well. For a score of 1 in IHC, a fish is indicated. False. If you are having a score of 0 to 1, then it means negative. If there is a score of 3, that means positive. For a score of 2, that means you are going to be having a unequivocal discussion. Tab agar score of 2 hota hai, then it would have been fish is required. So fish for 2. Increased cadherin expression makes breast cancer bilateral and multifocal. False. Cadherin means that it is bringing the tumor cells together. So if there is more cadherin expression, the tumor cannot be multilateral or bifocal, right? It cannot be bilateral and multifocal. Decreased cadherin expression can be responsible. Underactivity of CDH1 gene is associated with familial gastric cancer. That is true. So the statement was about 1 and 4 are true, but he is not asking us about true statements. He is asking us about the false statements. So the answer is option C. Right? This is what you need to remember, that whenever we're going to be talking about, the next question can be the brown color over here can be because of a staining in the membrane. Membrane staining is going to be seen as a feature of something like HER2 new. Membrane staining is for HER2 new, whereas nuclear staining is seen with ER and PR. Nuclear staining is seen with ER and PR, and membrane staining is seen with HER2 new. So the question was about not true for her. That is what you just need to remember. Right? This was the detail that we have talked about in the main video and one of the discussions of the PYQs as well regarding what is 0, what is 1, less than 10% of tumor cells if they are going to be having a very mild staining or no staining. No staining means something like this. If it is an example of a very mild kind of a faint staining, that is going to be, this is 0 staining, this is faint staining, this one is indeterminate, and it should be this dark brown. It should be this properly dark brown in more than 10% of the cells to say it is 3 plus positive. So 0 and 1 are negative. 3 is positive, 2 is weakly positive, and that is called as equivocal, for which we require FISH as an indicator. Now, ER is an example of a prognostic indicator. You can say, Doc, that ER is an example of one of the prognostic indicators. But ER will also tell you the fact that the patient is going to be having a response to anti-estrogen therapy. So it is also going to be a predictive marker. That is one of the INI questions that I know that there is a difference in the answer that has been given by other platforms and the answer which has been given on our platform. The reason is for this reason only. Prognostic factors can be multiple. It is a predictor to the response of anti-estrogen therapy, something which we are absolutely sure. Right? Which of the following is not correct is something I want you to keep in mind over here. Whenever we are going to be talking about FISH is not useful for point mutation. Again, this is something that we need to remember. For point mutations, we require next example of a test, which is a single base primer extension test. So not useful. This is true. FISH is required whenever you want to have deletions or whenever you are talking about something like amplifications or something of that sort. Right? The simple reason over here is that you are going to be requiring larger probes over here. So deletions, translocations, amplifications, that is what is going to be requiring FISH. Single base primer extension test is done for detection of point mutation. This is absolutely true. This was what was asked to you as a question in the exam as well. This is very, very important. The first one is also important. The third one that is mentioned over here is array-based comparative genomic hybridization cannot be useful for detect unknown deletion. This is false. Comparative genomic hybridization is useful for detection of unknown deletions and unknown amplifications. It is useful. It is useful for deletions and amplifications. If you know, it is a simple thing that we talk about in biochemistry as well. You are going to be using two types of color probes, red and green. Red and green. Red means deletion, green means over amplifications. And if both of them are present in equal amounts, then you get a yellow color. So this is true. Real-time PCR is performed on complementary DNA for monitoring residual disease in CML. This is absolutely true. Line taken from Robbins. So the answer is option C over here. Which one are you talking about, Doc? CGH wala. So yes, you are going to be looking at something like this. You are going to be having a tray. You are going to be looking at a tray. अगर आपको नहीं पता हो कि डिलीशन है या नहीं है ट्यूमर सैंपल के अंदर, ये अननोन डिलीशन वैसे वाला नहीं है. What you are looking at over here is you do not know whether there is a deletion or not. This unknown doesn't mean that there is no deletion. The deletion is what is known to you. It is taking place at a particular point, but you do not know whether your sample is having deletion or not. Right? So you are going to be having the presence of a yellow color. Yellow, 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 yellow. So yellow is not a dirty fellow over here. Yellow means it is balanced. Both of them are present in equal amounts. But let us say tumor cells who are having the presence of a red color, and there is a particular gene which is going to be having the presence of a green color. If any of the colors is present, that is an indicator that there is an imbalance, and that imbalance is what can be predicted. So this unknown means undetected, I can say over here. I mean, unknown in the given sample. Unknown over here means you do not have an idea whether there is a deletion or amplification. So as to confirm. Right? That is what you just need to keep in mind. A, B, D are true. C is untrue. Cannot लिखा हुआ ना यार. It can be. It can be. Which of the following is not correctly matched? I hope this one was easy. Ig mediated mast cell degranulation, skin rash after insect bite. This is true because this is a type 1 hypersensitivity reaction. Antibody dependent cytotoxicity is type 2. Penicillin induced hemolytic anemia. Penicillin induced hemolytic anemia is an example of type 2. This is true. This is true. Penicillin causing anaphylaxis is type 1. Penicillin causing hemolytic anemia is type 2. Just remember this. Because this will be an example of a drug-induced hemolytic anemia. Immune complex deposition in lupus is true, but not hemolytic anemia. SLE patients blood picture. SLE patients blood picture is type 2 hypersensitivity. Other organs, SLE is type 3. So the question would have been kidney involvement in SLE, lung involvement in SLE, cardiac involvement in SLE. That is type 3. But if the question says anemia, thrombocytopenia, or leukopenia in a patient having SLE, that is type 2. So the answer for the question is this one. It is not B, it is C the answer. That's a concept. Contact dermatitis due to nickel is something that is known to us. Contact dermatitis is most commonly seen in our country because of chemicals like washing detergents. Nickel and cadmium play a role because females are going to be wearing artificial jewelry. Pernicious anemia is type 2. यार कोई doubt ही नहीं है इसमें क्या है. Pernicious anemia is type 2. Then we are talking about the next one. 60-year-old chronic smoker presents with hoarseness of voice, significant weight loss, Cushingoid features. Age, smoking history, weight loss, hoarseness of voice, pointing towards something like a cancer, Cushingoid features. And the mass is positive for INSM1. So it is a case of a patient who is going to be having the presence of a neuroendocrine tumor, which is going to be given the name of small cell cancer. Remember, adenocarcinoma arises from adenocarcinoma in situ. Squamous cell carcinoma is associated with squamous dysplasia. But small cell cancer has no known pre-invasive phase. Small cell cancer has no pre-invasive phase. It's a question which is a repeat from what I have given you in one of the tests earlier. I just wanted you to recall that fact and just brush up that fact again. Small cell cancer is not having any precursor lesion. That's a concept. Kulchitsky cell tha, that was carcinoma tumor. That will talk about patient who's going to be having bronchospasm and diarrhea together. Bronchospasm and diarrhea. That will not have hoarseness of voice and weight loss. Bronchospasm and diarrhea. I hope INSM is what you remember. It's an example of a special stain which is going to be responsible for causing intranuclear staining. Intranuclear staining. Dipne is not for small cell cancer. This is Dipne, neuroendocrine hyperplasia. It is not for small cell cancer. The history of your patient is suggestive of a small cell cancer. This is not for small cell cancer. Right? Hanji. Which of the following chromosome 15 image has to be analyzed and the answer has to be given over here. So this is a normal one and you have a deletion of the gene present on chromosome number 15, right? That is what you are expected to be familiar with. Just a twisted way asking the same question. Paternal deletion is seen over here. Whenever we are talking about paternal deletion, the patients are going to be having a development of something called as Prader-Willi syndrome. Paternal deletion is what is going to be associated with Prader-Willi syndrome. So paternal deletion or maternal disomy. These are the two conditions which are going to be responsible for causing Prader-Willi syndrome. Maternal disomy or paternal deletion. So far as Angelman is concerned, that is totally opposite. Maternal deletion or paternal disomy. What is the clinical feature of Angelman syndrome? Mom wears sari. So maternal deletion, mom wears sari. Seizure, ataxia, retardation, and inappropriate laughter. Happy puppets. Seizure, ataxia, retardation, inappropriate laughter. What is the clinical feature in case of Prader-Willi syndrome? Prader-Willi syndrome. Prader-Willi syndrome patients are typically going to be thin or obese. They are going to be short. They are going to be obese. There is increased eating habit, hyperphagia. Why is a hyperphagia seen? Because of presence of increased secretion of a hormone that is responsible for their increased appetite, ghrelin, right? And yes, they are going to be having hypotonia as well. So ghrelin is an exam question. Short obese hypotonia is another exam question. Paternal deletion, maternal disomy are two different questions. And the only thing was that in the one of the recent exams in 2024, this was exactly what was asked in the form of an image-based question. Right? So next one. 60-year-old woman consults a doctor due to persistent malaise for 5 years and presents with high blood pressure. She passes away unexpectedly within a week and the autopsy reveals external appearance like this. So this is going to be polycystic kidney disease. Depending upon her age, this is classically an example of an adult polycystic kidney disease. Now, adult polycystic kidney disease is an example of an autosomal dominant or autosomal recessive condition. The answer is autosomal dominant. So first two options are ruled out. Now, what you need to remember over here is that typically this is going to be an example of a condition which is going to be having a very peculiar finding. नहीं flea bitten कहाँ लग रही है यार? Flea bitten नहीं है ना मेरे भाई? It's an example of a condition which is going to be having the presence of cyst. Cyst है भाई वो. हेमरेजिक सिस्ट है ना, ब्लड फिल सिस्ट है, इसलिए फ्ली बटन जैसी आपको हो सकता लग रही हो. हाँ, वो हाइपरटेंशन से आप कंफ्यूज कर गए, ऐसा मैं मान सकता हूँ. कंफ्यूजन हो सकती है, कंफ्यूजन को हम दूर कर लेंगे. बट दिस कंडीशन इज गोइंग टू बी हैविंग द प्रेजेंस ऑफ ऑटोसोमल डोमिनेंस एंड हाई पेनिट्रांस. हाई पेनिट्रांस, हाई पेनिट्रांस भाई. लो पेनिट्रांस वाला क्वेश्चन दूसरा था. These patients are going to be having a high risk of development of which complication in the brain? Berry aneurysm. Which is the complication in the GI tract of this patient? GI tract of this patient. There is high chance of diverticulosis, particularly colonic diverticula. What do we expect to see in the cardiac examination of this patient? Cardiac examination. High chance of mitral valve prolapse. Very good. High penetrance, low penetrance का मतलब होता है patients are having genes. Let us say 100 patients are having genes. How many patients are going to be developing the disease? So normally what is going to be seen is some patients will be developing a disease, some patients are going to be having a development of less chances of disease. So in this condition, who are the patients who are going to be having this kind of a gene problem, right? So there is an involvement of a gene called as polycystin gene 1 and 2. They are the patients who are going to be having high chance of development of clinical manifestations, right? So these are the other findings that we need to remember in these patients: high chance of mitral valve prolapse, colonic diverticula, as well as the development of Berry aneurysm. So therefore, the same question can talk about polycystic kidney disease and the patients are going to be having a development of a severe headache. Severe headache because of subarachnoid hemorrhage. Subarachnoid hemorrhage because of Berry aneurysm. Right? That is what you need to remember. What is going to be the cause of death in this patient? That is because of some kind of a coronary artery disease. Polycystic kidney disease.